Greetings, aspiring orthopedic clinical specialists. We are going to review our lumbar spine scenario today. And what we'll do is I'll talk us through the scenario. I will tell you how to review a scenario, give you some guidance as to how to review a scenario. I like paper. So for me, I highlight stuff. I highlight key points. I think when you read a scenario, you want to be sure that you're attending to all the information that you're presented. You don't want to ignore anything. If you ignore a piece of information, you're probably going to choose an option in a question that is incorrect because you ignored a piece of information. So make sure you attend to all the information that you're given. When we look at this lumbar scenario, the first thing we see, patient is a 72-year-old woman. Whenever I'm given an age, I pay attention to that. When I see an age, there are certain conditions that I start to make my hypothesis. There are certain conditions that I'm thinking of. These are more likely than these conditions based on the patient's age. So I always pay attention to age. I'm thinking about three areas: examination, differential diagnosis, prognosis, and intervention. So I think about age, and that can certainly help me think about what condition might be present and how I'm going to manage it. This is a woman, so gender can make a difference as well for certain conditions. So I pay attention to that. We're told lives by herself, occasional walker, active in the community. So we're getting a picture of what this woman looks like. So that really helps. And then we're told her condition. This morning she slipped. Oh my goodness. It landed on her buttocks. Immediate upper and middle lumbar spine pain. So we have a mechanism of injury. This is a traumatic injury. This is not something that was insidious. It didn't start 8 months ago. It happened today. So that's really important for us. She was able to come to the clinic. So that's important information as well. She talks about 8 out of 10 pain. So we know that it's pretty severe and pretty intense when she tries to stand up. She has no complaints of lower extremity pain. And we're told her neurological exam is normal. So you might have been thinking about some other certain conditions when you saw the mechanism of injury. And then as we get more information, you're thinking, okay, that neurological examination is normal. So now I'm less likely to think of maybe some other conditions I was thinking of. So that's how we want to use all this information that we're given right now. We kind of want to use every piece of it and start to form a hypothesis about what we're thinking. First question we're asked is, what's our suspicion for a vertebral fracture? We're 72 years old. We're a woman. We had a traumatic injury. So we look at our choices. 2 of them give us low options, and 2 of them give us high options. So I'm thinking high because of our age and our gender. So then that gets us to C and D. D is the better answer because we used gender and we used the age. Whereas we look at C, it says anyone who slips on a wet floor is likely to have a fracture. Not true, obviously. D is the best answer here because we have to use all the information we're given. And it also makes sense from an evidence-based standpoint that we know that as age increases and female gender is more likely to experience this type of injury from this type of trauma. So D is our best choice here. And then for our second question, additional factors are most likely to raise the likelihood of a vertebral fracture. So we're thinking, okay, what else would either I see in my exam or would be present potentially in her history that would increase my suspicion of a vertebral fracture? And our choices are history of cardiovascular disease, obesity, prolonged use of a non-steroidal anti-inflammatory, prolonged use of corticosteroids. So hopefully we all remember those corticosteroids. They're wonderful if you have breathing issues or if you have a cold. But if we take them long-term use, prolonged use of corticosteroids, they weaken bone. So that's our best choice here. Those other factors don't raise the likelihood. They may raise the likelihood, but they don't raise it as much. On this exam, you may see a question and you may look at all the options and say, I think all these options are correct. That may be true, but there's one that's going to be a better answer than another. We're trying to evaluate if you're a clinical specialist, and you should be able to know, given a series of options that all might be okay, which one is the best choice out of them. So for this one, corticosteroids is the one that would raise our index of suspicion the most to the likelihood of a fracture. Now for this next question, for 3, we are given more information. So anytime you're given more information that the case has progressed, you want to attend to that because we're not dealing with the initial information we're given. Now we're told that she had plain film radiographs and a CAT scan. So now we have some imaging that's gone on, and there was no evidence of a fracture. So that's obviously important to us. She comes back to the clinic. She says the pain has gone down. Oh, that's a good thing. But bending forward or sitting more than 30 minutes increases that pain. And now we have on examination. So we were given the results of some testing and we were given her subjective report. So we kind of put those pieces together, and now we have some examination findings that are going to be coming. So I kind of just parse them separately in my head so I can keep them straight, and then obviously we want to put them all together. So on examination, we notice tentative palpation over the lumbar erector spinae, but not over spinous processes in thoracic and lumbar spine. And we're only given this information, and the question states that, what should her treatment be? So now we're asked for an intervention, again, based on the initial presentation and based on the information that we were just given about radiographs and some more and some more objective findings. And we look at the choice. We're given a choice of avoiding activities. We're given a choice of encouraging graded activity. We're given a choice, maintain substantial reduction of activity. And we're given a choice of prescribing a lumbar orthosis. Our best choice here is encouraging graded activity, especially walking. That's what she had done before, so that's important. And evidence does suggest that this will be helpful. We want her to stay active, especially if we know that there's no fracture. Staying active is the best thing we can do. So avoiding activities that are painful and using a mortality-based approach, that's not good, because if she says, if it hurts, I'm not going to do it, she's not going to move. That's not what we want to do. Maintaining a substantial reduction in activity because of the age, that's not appropriate. We want to keep this woman moving. And a lumbar orthosis is absolutely not appropriate because we don't have any active fractures. We want to keep her moving. We may do some things to mollify her pain, but we want to keep her moving. So the best choice here was that graded activity, and walking was a great choice because since she had told us that she had done that before the injury. So that was our lumbar spine case scenario. I think it was a good one because it presented a traumatic mechanism of injury, and then we had to deal with the patient's age as well. So that just illustrates that you need to know mechanism of injury, what conditions are most likely. It illustrates that you need to know age, because if this was a 25-year-old, some of these questions may have gone differently. So we need to attend to all that information that this scenario really presented that to us and really showed us. We have to attend to all the pieces of information we're given to answer every question correctly. So hopefully that helped us understand that process a little bit.